housekeeping before we start. Obviously your cameras and microphones will be off, but the chat function is available, so you can ask any questions or raise anything that you do want to raise. And there will absolutely be opportunity for Q&A at the end as well. So what are we here to talk about today? We're going to talk about myth busting. There's lots and lots and lots of beliefs and perceptions, I guess, in our musculoskeletal world. And I'm very honoured to be joined by Trace today. And we're going to have a bit of, I guess, a fireside chat. We've got lots of infographics, I guess, to share with you and talk about, and hopefully dispel any myths and beliefs that you guys might have, and that you can also share with your colleagues, friends, and workforce as well. So just, I guess, to introduce myself, my name's Claire Glynn. I'm a physiotherapist by background. I'm the Clinical Operations Director at PAM Physio Solutions, which is part of PAM Occupational Health Group. And I've been in practice for 20 years. And then we've got Tracy with us today as one of my esteemed colleagues. Go ahead, Tracy.
Thank you, Claire. Yes, welcome to everyone this morning. Thank you for joining us. So yeah, my name's Tracy Atkinson. I'm the Clinical Governance Director for PPS. Like Claire, I'm a physiotherapist by background, and dare I say I've been practicing now for 31 years and worked in occupational health for the past 28 years.
So what we're going to talk about today, we're going to have a look at the most common myths and conceptions. And I guess myself and Tracy have had quite a bit of time looking into this and the things that we've experienced in our careers. So we wanted to make sure we brought those up, because they're, I guess, old myths, but they're still lingering around. And then obviously tips and tricks for recovery, and that includes at work and home. We are obviously occupational health clinicians, so work is really, really important to us, and making sure people are efficiently at work and returning to work. And then finally, we're going to have a look at the benefits of workplace occupational health physiotherapy as well, and Tracy's going to do a few slides just talking around that.
Lovely. Right, so I think the first area that we're going to discuss is diagnostic imaging. So, you know, there's a perception from a lot of people that often, in order to be able to get any answers or a true diagnosis of what their pain is, that they actually need more investigations, such as, you know, the common ones that we often come across, don't we, Claire, are things like x-rays that obviously are used for looking at sort of bony type injuries, MRI scans, so what we call magnetic resonance imaging scans, which are basically used to look at more sort of soft tissues and organs within the body. And another common one that people often get referred for are CT scans. So what stands for computerized tomography, which again looks more at sort of 3D x-rays, and ultrasound scans as well. So like I say, there's this often belief that we'll get a lot of patients, don't we, Claire, who come, and I think their expectation is, well, you know, we don't know what the problem is, so you need to send me for a scan or some further investigation.
I think the one that sticks in my mind is where we speak to people and they'll tell us that they've got pains or problems, and then, you know, we'll just say to them quite casually, have you seen a physiotherapist? Have you sought an appointment? And actually they're avoiding going to see a clinical specialist because they're waiting for a scan, and they want a scan to give them their diagnosis. Whereas actually what we absolutely know is that, number one, waiting for a scan or any kind of diagnostic imaging delays any kind of diagnosis, and actually during that time the chronicity of the condition actually gets worse, and therefore symptoms get worse. But we know as physiotherapists, when it comes to musculoskeletal conditions, we can diagnose people in a consultation 99% of the time. So we're able to establish through subjective questioning, so discussions with the individual and then with objective examination, we can diagnose people with their musculoskeletal conditions without the requirement for a scan. And what this and I must say I absolutely adore this infographic, but what this infographic shows us that scans are pretty pointless, if I'm completely honest, unless there is any inconsistency in people's presentations or any urgency in people's presentations. Because what you can see here is that thousands of people that had no symptoms whatsoever underwent scanning. and diagnoses were established, but people were completely functional. They had no issues. They were completely functional in their day-to-day activity. They were in work. There was nothing wrong with them, but really high percentages of them had something that is worth a level of label. So what we can establish from that is that someone who has got pain, who then undergoes any kind of diagnostic imagery or scanning, may identify something that's actually not related to their pain and symptoms in any way, shape or form.
Yeah, because as you say, Claire, a lot of these scans, and you know, it's good that you've picked up on a lot of the research that's been done where they've scanned asymptomatic people, and it shows all of these normal changes that we get within our bodies anyway. As it says there on the infographic, it's just like us getting grey hair or wrinkles. As we age, there are normal changes within the body, and these will show up on scans. I think the issue then is often when people do go for scans, it can show these changes, as you say, and then people think that's what's then often causing the pain. And as we know, a lot of these issues and problems people have, it can be very much influenced by a wide variety of different factors. But then people sort of home in on, well, this is what my scan said, so this must be what's wrong with me. And it can sometimes do more harm than good, as you say, because it can then delay people's recovery, because people then don't sort of progress on to doing what they should be doing. They're sort of in this limbo area where they're waiting for scans, or, you know, once they've got the scans, waiting for results. Once they've got those results, fixating on, well, this is the problem, this is what I need. And it's often not the case.
Yeah, I think as a society, we're fixated, aren't we, on labels. A term's just popped into my head that I haven't heard for years, but I know used to get battered around a lot. Do you remember the old, yes, your diagnosis is lumbago? Lumbago, yes. Latin for lower back pain.
Yeah.
Brilliant. And it's a label that means nothing.
No. And the thing as well is a lot of the research now, you know, if we're talking about back pain, 90 to 95% of back problems are what we now class as mechanical or non-specific back pain, isn't it? Because there's so many different contributing factors, it's very difficult to identify one true cause of back pain. And there's only, I think the up-to-date sort of stats show about 5 to 10% of back problems where there is a correlation possibly between the symptoms people are having and then a positive investigation finding. So it actually is very rare when we obviously assess and see people that we actually feel people actually need to go on and have further investigations, because actually there's so much more advice and support we can give people to help overcome that pain and discomfort that they're getting.
So the first myth that we are busting is that the perception of a need for any kind of scan or diagnostic imaging. It's not needed. Seek the help of the professionals that can actually help you before the requirement for an image. Don't delay.
Yeah, absolutely. So the next one is, again, this is a common one we come across as clinicians, is that many people think that following an injury, it's often better to rest and avoid doing the things that are obviously causing the pain, because if they think something's causing pain, then it actually means harm or damage. And that's quite a common one that we do come across a lot with patients. And this is an area where I think we have to do a lot of myth busting with people to give them that advice and education, don't we?
Yeah, we're conditioned all the way through our childhood to avoid something that hurts. So fire hurts bad. Standing on the upturned plug and the Lego hurts, it's bad. But then you come in to see a physio and we go, oh yeah, no, it hurts, but keep doing it anyway. And it's about the acute pain and the trauma that's caused the pain, but then the conditioning of the muscles. So it's a really hard thing for people to, I guess, get their heads around when we're saying, no, I know it hurts, but do it anyway, just to a certain tolerance level. And it's because of the way we've been conditioned. But if you think about back in the day, it wasn't it, where you'd go to the doctor and say, I've hurt myself, and the doctor would say, bed rest. And I'd love to believe that there's not a single doctor now that says, you know, bed rest is required. But I'm sure that people do still come across that recommendation to rest and to avoid activity that they believe is hurting them or making it worse, or that pain needs damage and harm.
Yeah, absolutely. And again, as we we've done more research and understood better about these type of problems, we now know that actually avoiding activity and resting is actually quite detrimental, don't we? Because it can actually lead to higher levels of pain, as you say, greater disability, poorer recovery, longer absence from work. So all of the evidence out there shows that actually getting people moving and getting them back to doing those activities, as you quite rightly say, it's doing it in the right way, graded activity, gradual exposure, so that we're not exacerbating the problem, but it's trying to get people over that fear that actually that movement is going to mean harm. And going back to the point you were making, Claire, I think as medical professionals, unfortunately, sometimes don't help, because as you say, sometimes they won't be given the right information. And I'm sure people have come across sometimes the wording that medical professionals can often say. So I've had patients come to me and they've been told your back is crumbling, you know, or you've got degeneration or wear and tear, or, you know, you've got a slipped disc. Now, if you're being told that type of information with that type of sort of wording or terminology, it's not surprising, is it, that people then think, oh my God, if my back's crumbling, why on earth would I want to move? So I think as well, it's making sure that we sort of get the right positive messaging across to people, that, you know, backs are stronger than, you know, we think they are. They're very robust. Our bodies are actually very resilient and very good to recovery. So it's making sure that, like I say, we're getting that right messaging across to people to get them moving ultimately.
Yeah. And I think in a few slides' time, we talk about negative language and terminology, don't we, around people's conditions. And sometimes we talk about not over-medicalising and not providing unnecessary investigations, but equally being able to explain to someone their condition or diagnosis without making it too undermining is also equally as difficult. And I think what we can say as physiotherapists, and especially as occupational health physiotherapists, is that we've had quite detailed training and experience, haven't we, making sure we can explain someone's pain and symptoms to them in as much clarity as possible, to help them understand. Because like you say, if someone's you can have a whole 30-minute conversation with someone about what's going on with their body, but as soon as they hear degeneration or crumbling or wheelchair, absolutely the fear is going to set in straight away, and the rest of the conversation just flies out the window. So you've got to make sure that every word spoken is absolutely right to prevent fear avoidance, to prevent people from being scared to do something because it's going to cause more problems. And I know we've spoken about this before, haven't we? I love the terminology stress healing. The body is a biological item, and as a consequence it needs to be told what to do and how to heal. So if the bone is broken, you've got to tell it where to fix. You can't glue it back together, it's got to glue itself back together. And to do that, it's got to know where the problem is. So you've got to have a little bit of movement, a little bit of pressure and a little bit of stress through it, so the body knows how to heal itself. And that's the same with the soft tissues as well, skins. You know, I've told you a story before about, you know, treating someone who had a Zillerov frame when I was right the way back, newly qualified, and it just been the most amazing experience. And if anyone wants to have a look at what a Zillerov frame does, it's absolutely phenomenal, and that is the perfect example of stress healing.
And again, I suppose the stress healing also feeds into that sort of adaptive loading as well, doesn't it, Claire? Because again, the only way you can adapt and you know, re-educate and train tissue and muscle and bone is by gradually building up that stress and loading onto it so it can cope and adapt with it. And again, this is why it's often you know, an issue when people have been off work, because they decondition because they're not being exposed to that sort of loading that their body's used to. So this is why it's important to sort of bring people back gradually and sort of build up that loading. You know, a good example I use of that is if I turn around to you tomorrow and said, right, I want you to go and run the London Marathon, you know, apart from obviously, apart from you laughing at me and looking in shock, you know, I sort of say to people, well, what would you have to do in order to be able to go and run the London Marathon? And everybody's, you know, they'll all come up with the same answer. Well, you have to train. Well, absolutely. And why do you have to train? Because you've got to give your body that chance to adapt and adapt that loading and stress and strain on your body to reduce the risk of injury. yet people don't seem to think about that scenario in relation to work. And it's exactly the same principle. If you've had someone who's off work for a long period of time, they will decondition if they're not exposing themselves to that type of movement and loading, and hence why it's important to get people back to work soon and use that as that process for that adapting loading as well.
Yeah, exactly.
Brilliant. Okay then. So the next one, massage. So again, we often do come across people who have this perception still, I think, an expectation that if they are being referred for physiotherapy, they are going to get a massage. And we do still have people coming back to us querying this and sort of, you know, not necessarily, I would say, making a complaint, but asking the question, you know, why hasn't this been incorporated as part of my physio session?
The magic sponge. Do you remember the magic sponge at football?
Oh,
cured
yes.
everything, didn't it?
Absolutely.
Same as the massage cures everything. I mean, I'm going to be slightly controversial because I do think that elements of manual therapy, not necessarily massage, but elements of manual therapy do contribute to a mixture of modalities. It is absolutely categorically not to be used as a sole remedy. It's impossible. It can't be. When you look at the research of actually how tough the muscles are, us pummeling around in someone's muscles actually doesn't have the effect that is experienced. So that numbness and that release is extremely temporary, isn't it? But there's absolutely the expectation that that's what's going to provide at every single session. And actually, in many conditions, it's actually derogatory, because it would actually cause more harm than good. There's a whole volume of spinal conditions and arthritic conditions where we cannot physically perform any manual therapies, and therefore we wouldn't as qualified healthcare professionals.
Yeah, and again, there's a lot of research now as well to show that actually successful recovery plans is a lot more about that education piece, getting people to understand what the issue is, why, exercise, and it's more about that self-management piece for me, and people taking more responsibility for their own condition. You know, I think, as you say, Claire, massage can be part of that process to help get them to that point, but it can't be the sole thing that people are getting. And like I say, it's that sort of self-management that's key, really.
Yeah, and the more it's employed, the more that passive modality of massage or manual therapy is employed, people become quite dependent on it. And I have friends who say that, you know, they go for a massage once a month because it really helps, and that's absolutely fine, but that's a holistic massage. It's not actually doing anything for their biological and physical health. It's holistic. It makes them feel better, which is brilliant. It's great that they found something, but it's not for a physiotherapist to kind of give that out without looking at the long-term outcome. Yeah. We as physiotherapists are always looking at the long-term outcome. If we look after you and help you and support you for a 6-week period following injury or illness or a condition development, we don't want you to come back because you've had a re-exacerbation. We want you to go away and have all of the tools that you need to be able to have long-term success and long-term recovery. If you have to keep coming back because you're engaging in the requirement for some kind of passive modality or manual therapy or massage, then we've failed as clinicians. We have absolutely failed. Short term, it has absolute positive impact, but long term, people need to know how to look after themselves.
Yeah, absolutely. Okay then, next one, manual handling. So
it's your favorite one, Tracy.
Yes, and it's really interesting because obviously I've been sort of delivering manual handling training for a long time, and again it's now perhaps now we've got sort of more understanding again about our bodies, how we move and how to move efficiently. Some of that sort of research and evidence now that's coming out is starting to maybe change how we approach this. For a long time we've been very much taught about the fact that you have to sort of bend your knees and keep your back straight when you're doing your manual handling. Now, to a certain extent, by obviously using your legs, that is a good thing. It's an efficient way of moving because you are using your power muscles in your legs. But I think a lot of people have become very hung up about keeping their back perfectly straight. And actually, when you look into the real world and what people do on a day-to-day basis and the tasks they do in the workplace and at home, because again, if you think about manual handling as moving, using your body to move any sort of object or load, we do a vast amount of manual handling every single day, all day. But we don't tend to think about it until you maybe start to lift those heavier objects. And actually, by keeping your back completely straight, it means sometimes people can't move efficiently. And actually, a lot of the evidence now is showing that there isn't a sort of direct correlation between sort of bending your back a bit and the risk of back pain. And even the regulations now have started to sort of be reviewed and updated, and actually it does indicate about using a little bit of back flexion to be able to get into more efficient ways of actually moving and handling. And again, we're all very different, you know, we're all individuals and we all move slightly differently as well. So again, it's trying to come away from this very prescribed, rigid way of doing it, but teaching people more the tools about risk assessment, how to move efficiently, how to look after their body more effectively and be more proactive to reduce that risk of manual handling. So I feel as if, you know, we are starting to see that little bit of shift on how we sort of approach this and sort of give people that sort of awareness and education.
Yeah. The way I always look at it is that everybody's body is completely different. Everyone's got different habits. Like you said, everyone's got different ways that they move and do things. So, you know, a gymnast moves completely different to a footballer who moves completely different to someone who's only just engaging on a health pathway, you know, through park run. So what we're not saying is that, you know, if you've always engaged in the 90-degree knees and straight back, don't just go straight into, yeah, I'm going to twist my spine round and lift up with a completely hunched back, because you are opening yourself up to risk there. But what you need to be reflective of is understanding what your body can do and how strong your shoulders are, how strong your back is, how strong your legs are. And that will sort of almost dictate to you what your manual handling strategy and performance is. I've always said there's a million wrong ways of doing it, but there's no right way, because the way you do it will be completely different to how your neighbour does it, or your colleague does it, or your friend does it, any kind of movement or technique. And you can see here there's two people doing a lift. You need to make sure that if there's two people doing a lift, completely different way, that you're in sync with each other and that you understand what each other are going to do. So you're not putting the other person at risk because you've got a slightly nuanced way of lifting or performing any manual handling.
Yeah, and that's a really good point as well, Claire, because like I say, it does go back then to that risk the importance of risk assessment, people understanding what those risks are and how to identify them. It's them putting into practice the correct principles of manual handling. But as you say, everybody is slightly differently, and it's really interesting because when I do go and sort of deliver manual handling training, we always try and ensure that we make it bespoke to the actual tasks that those people are doing, because again, for many a year, I think people have often been taught, you know, lift with a cardboard box. But again, the reality is if you're not using a cardboard box for everyday tasks, we need to make sure people can translate that information into their working environment and ensure that they are doing it safely, you know, and effectively and efficiently as well.
Yeah, it always used to be, didn't it? A cardboard box with handles at the right location onto
Absolutely.
a shelf at trunk height, which is absolutely not the realistic world in any way, shape, or form, especially if you know in blue light services. Where the environment is unpredictable and you know the actual handling is completely unpredictable. So yeah, it's been really pleasing to see, hasn't it, that the HSC updates have been more up to date with what's the realistic situation and about bespoking manual handling, not having a video that's seen as one size fits all for any industry, but actually what we're able to do is promote and prove that we need to go on site and develop bespoke manual handling to a site and to an industry, which is far more effective for any organisation.
Absolutely. So moving on from manual handling then, DSE and ergonomics is another one. So again, I think, you know, for many years we have had regulations. There are obviously the gold standards and ergonomics to put into practice. But again, I think the key thing for me when we're looking at people with from a DSE ergonomic perspective is that you can still have obviously a very good chair, a really good workstation setup. Again, you're applying all the principles, but the key thing is we are not designed to sit for long periods of time and not move. So for me, the key is actually getting people to move on a regular basis and change their position and posture on a regular basis. Again, I think people get very hung up that they have to be in sort of one set posture for a long period of time. And again, even in this sort of more ideal sort of alignment, your muscles and are going to get tired, your joints are going to get a bit stiff and achy. So you've got to get up and move and change position and posture. And I really like the phrase, and I use this a lot with my patients and when I'm doing training, your best posture is your next posture, because actually it's that movement, it's that fidgeting, it's that, moving around from one area to another that's actually key to reduce the risk of people getting these aches and pains.
Yeah, there's an infatuation, I think, isn't there, about all the bells and whistles and the toys and tools and the furniture and the equipment. And you can have all of that, but if you don't use it right and you don't move, it's not going to make the blindest bit of difference. And we've got, I guess, into a culture of, I don't know, are we fearful of moving away from our desk because we're expected to be available for the Teams call that might come through and people are home working more? But the furniture and the toys and tools have nothing to do with your health at your DSE. It's about moving and, again, how you use the tools that you have, and everyone's setup will be different because of everyone's different habits again as well. And I always go that one step further, I think, as well, which also talks about people's concentration. So the INC have identified that in an 8-hour day, without the appropriate rest breaks and moving away, a human being can actually only be productive for 2 hours and 53 minutes. So that's just over a quarter of the working day. So it's so important that people move away for those micro breaks and rest breaks to increase their productivity. Otherwise, there's just no point.
Yeah, and there is also research to show that actually for those people who do have regular rest breaks and move, guess what? They are actually more productive. Yeah. So it's really important to have those breaks where, again, people have got into these habits, I think, of sitting at the workstation and having their lunch or breaks and not moving away and changing their position. But actually, longer term, you are more effective. The other interesting thing is, again, on the back of obviously what we've gone through with COVID, and now people are doing a lot more home working or hybrid working, people are working for longer as well. Yeah. So again, we've sort of shifted from people maybe sitting at a desk for maybe 7-8 hours a day. There are now is an increase with people working from home, that people then tend to do sort of more 9-10 hours because they haven't also got that commute to and from work, which again gives you that opportunity to sort of start to prepare yourself for the day, then decompress. And it's learning as well to then separate the sort of the working day from home life and getting that balance, which is really important in what we talk about.
It is. I think the DSE and ergonomics, I mean, I'm so passionate about DSE and ergonomics. It's such a massive education piece that we can absolutely help support people with, because actually people just understanding their own bodies and what they can do to help themselves is so incredibly important, isn't it? And I do wonder how many people still use the terminology in inverted commas gold standard, which is always something that was thrown around, wasn't it? And I do think we're doing better at moving away from that. I think COVID has been partly contributory to that because of everything that you've just said about people not actually performing a commute, people working longer hours, people sitting at home, people being so used to just being available 24/7 on a Teams call or a Zoom call. So we have been out there and educating people that it's okay to move, it's okay to do a fake commute, which is walking around for half an hour before you start work and walking around for half an hour after you finish work, to separate it all out. But there's still a lot more that needs to be done and that can be done.
Yeah, absolutely. Okay, returning to work. So again, this is quite a common one in the fact that, again, I think people believe that you need to be 100% fit to return to work. But as you and I know, Claire, that's not the case, because again, the whole point of often returning to work is that should be seen as part of that rehabilitation process for someone, to actually start to encourage them back to be exposed to those different sort of job roles and tasks, to allow that great, that stress healing, great adaptive loading, graded exposure, to make sure that actually people are getting their optimum recovery. And as long as it's done in a very controlled and safe way, good work is good for us.
Yeah, and I think there's multiple, I guess, target audiences for that message. There's the individual themselves, the person that's experiencing their barrier and their difficulties, and we need to primarily help that person understand why getting back to work is going to help them in their recovery more than anything else. But also a manager needs to understand how to support and assist that person back into work in a safe, efficient method that's not going to fail and then set everyone back a number of steps. But also the employer, the organisation, what's operationally feasible for them to support the manager in implementing to support that employee back into normal function. And work is part of normal function, and that's what we're trying to achieve, to get people better quicker, and that includes all elements of their function, not just the social aspects, but that biopsychosocial model.
And there is some actually quite shocking statistics and evidence, isn't there, to show what the impact can be of not maybe identifying these problems and supporting that return to work quickly. There's lots of data out there, but I know some from the DWP, and actually if someone's off work for 4 weeks, then they have an 80% chance of returning back to their sort of full operative capacity or full duties. So, 1 in 5 people, even after 4 weeks, are potentially going to struggle to get back to their normal duties. If we then take that to 6 months, then that reduces down to 20%. So 4 in 5 people are less likely to get back to their normal duties. And what's quite shocking is that if someone's been off work for 2 years, the data actually now shows that statistically, you have more chance of dying than returning back to work because of the impact. So, it is quite shocking when you do look at some of the data and statistics out there of what the impact of not getting people back to work or supporting people back to work effectively can have on the individual.
Yeah. I don't think it's shocking. I think it's terrifying. And I think the fact that there are people that have been experiencing, number one, people have been experiencing musculoskeletal ill health for 6 months. Who's providing the support? We need to make sure these people have support. But we also need to be, exactly as I hope we're trying to do right now, is reverse those misconceptions about work and returning to work, and about fear avoidance and what's good work and what's bad work and what is healthy to help people to recover. But also educating people from our occupational health perspective that the sick note, now called the fit note or the Med 3, is a legal document to allow people to get statutory sick pay. It's not a document that states that someone is not fit to work. Occupational health and our reports and our advice as occupational health specialists are better, more trustworthy than a GP fit note or an AHP fit note.
Yeah, and I think a lot of people don't. They're probably not aware, because again, I think a lot of people know that obviously they go to the GP to get what we now call a fit note. But from July 2022, legally now, as physios and also occupational therapists, pharmacists, nurses are also legally able to now complete fit notes, Med 3 forms as well, which is quite significant when you actually understand that GPs issue about 10 million fit notes a year alone, in England alone. So that's a massive amount of fit notes that GPs are just dishing out to people. And often, again, as you say, they're not the specialists, we are. So they don't understand the person's work environment, the job tasks, what they can do in work. So often people will go to a GP and get a fit note or a sick note to say that, they're not fit to be at work.
Yeah.
That nicely sort of takes us on to just this infographic here, which does just hopefully emphasize the importance of work as a health outcome. The difference it can have on someone's health can be quite considerable. You can see there for the negative cycle, as soon as people are being signed off, they're not able to do, they're not being at work, they're not sort of having that sort of interaction, it affects people in lots of different levels. It could then impact on income. It can then start to have negative lifestyle changes. Then it starts to have those mental health issues, because we know there's a massive link, don't we, between physical and mental health, and one will often sort of, coincide with the other. And that negative cycle can then start to have a massive impact on the ability for that person to return to work. Whereas again, if we have that positive cycle where we have that early discussion, early sort of return, supporting any adjustments, giving people that sort of awareness, help, support and education, that can have a massive impact. And as we say, just the ability to get back to work does have a big impact on outcome for health overall.
Yeah. I think this slide as well, it goes right back to the earliest slides talking about fear avoidance and diagnostic imaging. You can see there in the positive cycle of health, exactly as Tracy just said, the early discussion with an allied health professional about the condition will support an improved rehabilitation process. So not delaying, not waiting for diagnostic imaging, not waiting to be scared to perform certain movements because they hurt so much. So you end up in this position where everything feels like it's falling around, and then engaging in conversations, but actually getting that support as early on as possible is what's going to help you recover and not experience all of those derogatory health cycle negatives.
Yeah, absolutely. So that sort of leads us on quite nicely to another area we often do get quite a lot of sort of queries in, I would say more so than anything, particularly from referring managers, is that the recommendations that as we as sort of health professionals and occupational health professionals provide in relation to someone's fitness for work and what we feel would help support that person in either returning to work or actually remaining in work as well.
So sorry, go on, carry on.
No, go on, Claire.
So the biggest part to kind of identify around this as well is that recommendations are recommendations. They're not written to the law, are they? It's about what is operationally feasible for an organisation to implement alongside our recommendations. And we talk quite a lot about trying to advise what someone can do rather than what someone isn't able to do to help managers facilitate and guide someone back into work.
Absolutely. And as you quite rightly say, Claire, it's exactly what it says on the tin, isn't it? They are recommendations. We are giving our professional advice and support and guidance. It's then for the manager to determine whether that is feasible to be able to put those in practice or not. But we often get managers coming back to us going, well, you've recommended this, but we can't do that. And it's like, well, yes, okay, well, it's whatever's operationally feasible for you. But sometimes it's then having that relationship and being able to have that communication and discussion to say, well, okay, then, if this isn't feasible, what would be? And we can then provide some further help and support and guidance as to whether that would be suitable for that individual or not. So it's not a case of, oh, we've recommended this, if you can't, that's it. It's then having those good relationships, communication, discussions on what we can do to work together to support that.
Yeah, and that comes a lot with, I guess, being the fact that we are in the world of occupational health, where part of our role is to understand the majority of what is and isn't feasible within our clients' industries and organisations and the buildings and the job role. And by us having that, I guess, insider information over and above maybe a primary care AHP means that we have the capacity to understand, okay, if we make this recommendation, we might be able to help get you back in a little bit sooner rather than later. But we need to see if they can accommodate this first, because it's a little bit outside of the box. But being able to work with an organisation to support that is where our strength lies.
Absolutely. And a classic question we often do get asked and queried is that we'll see somebody and give obviously advice and recommendations. And then the manager will often get in touch and say, oh, well, this person, again, has seen their GP and been given a sick note. And that's conflicting advice. But going back to what we were saying earlier, the fit note is a recommendation anyway. That's all the fit note is a recommendation. And quite rightly, we as occupational health specialists understand the workplace much better than a GP, and we spend a lot more time with the actual employee assessing their fitness for work than a GP would as well. So if you have that conflicting advice, you know, whose advice really are you going to go with?
Yeah, exactly. We need to, I guess, help overcome that, because there'll be lots of organisations that don't have access to occupational health, or specifically to occupational health physiotherapy. That doesn't mean that we can't provide help and support on a higher level around what organisations can do to help support their colleagues.
Absolutely. So just to maybe just summarise and sort of finish off with then, is to sort of look at what the benefits of obviously workplace occ health physio have. And hopefully with the discussion Clara and I have had this morning, it'll make sense that, again, it's a very business focused service. It's understanding the workplace and what the requirements are of both the sort of the employer, but also the employees as well. It's ensuring that we can align to sort of relevant health and safety and any well-being objectives that the organisation has, but also generally as well. It's a support surface to management. So again, because we've obviously been discussing about recommendations, it's us providing that professional advice and recommendation to allow you as managers to support your workforce. Key, as we've obviously gone through a lot this morning, is about that return to work treatment and using that as part of that rehabilitation process and overcoming that fear avoidance that a lot of people do unfortunately go through. And it's about control of health risks through following the right legislation, reducing litigation, and helping to reduce that absence as well. So there's quite a few key areas that we can help support with. So what do we actually do? Well, again, a lot of our work is about prevention, which again, we've talked about a lot. If we can prevent and educate and support people, then prevention's much better than cure. It's about assessing that fitness for work, how we can facilitate that return to work or keep people in work. It's supporting health promotion and education. We do quite a bit of sort of research, audit, and look at trend analysis. So again, it helps a business or organisation perhaps understand better, well, where are they getting their hotspots for MSK issues? And again, how can we support the business to identify, well, potentially what's causing these issues? What sort of proactive initiatives can we put in place? It's supporting that risk assessment and training. So again, we've talked in relation to manual handling and DSE this morning, and that treatment, fast track rehab, getting that early intervention, early support. And as we've discussed, we know, and there's evidence to show that the outcomes and health outcomes are so much, but they're much more effective if we see people early. And then this last slide just again shows the benefits to the employers and employees. I'm not going to go through each individual one, because I think a lot of the key areas we've actually discussed as part of our discussion this morning. Okay.
So I guess that's all from us on the slide deck presentation side, and we really do thank you for joining, Tracy and I. We would like to invite you to pop any questions that you have into the chat function, and we'll give you a few minutes. We'll be happy to answer any of your questions. In the meantime, yes. In the meantime, whilst you're all hopefully thinking up some really good challenging questions for us, I'd just like to share this slide with you, which is a link to our website, and this holds a plethora of downloadable resources, blogs, videos, useful guides, leaflets, handouts, podcasts, and also exhibits our service provision. Do feel free to have a look at that, and these slides will be shared with everyone that's joined today, so you can have a look afterwards as well. And whilst we still wait for some more questions to come through, we can invite you, or we'll invite you to join our mailing list, which allows you to receive all of our latest news and updates and invites to free events, webinars, and again, a nice volume of supporting materials to help you with your health and wellbeing, to support your colleagues and your workforces. Just open up the chat function, Tracy.
Right.
Oh, thank you. Just had a comment from Carol. Carol says, this is going to stroke our egos, Tracy. Excellent interactiveness between you. You can tell we've been working together for a while, can't you? One stops talking, the other starts without pause. It's not scripted or anything either, is it? I'm really pleased. No. Thank you, Carol. There's no questions come through yet. Okay. Oh, there's a question in the Q&A. Let's have a look.
I'm going to stop sharing.
Right, could you please clarify, this is from Chandy, so can you please clarify what is the difference between manual handling risk assessment and ergonomic risk assessment?
Right, so manual handling risk assessment is, again, it does what it says on the tin. It's specifically looking at manual handling operations. So anything where obviously you are manually transferring or using your body to move a load person, whether that's pushing, pulling, lifting and carrying team lifts. An ergonomic risk assessment is sort of looking at the bigger picture. So ergonomics can be applied to quite a few different key areas. So it's not just looking at manual handling tasks. It might be looking at sort of overall posture and positioning when people are carrying out particular job roles. It might be looking at sort of repetitive tasks. So ergonomics is more sort of looking at the wider picture of all the tasks and how we can look at being more proactive and preventative.
Yeah.
The manual handling is incorporated.
Yeah, so the ergonomics could look, going up and down ladders, up and down stairs, getting mechanics moving underneath cars. They don't have to necessarily be performing any handling whatsoever, but the manual handling risk assessment will address specifically only the manual handling. So we've got an updated question on the back of that one. I can see that it landed. I can't see where. So should we have separate or can they be combined?
They can be combined, so again, what I get involved in going out to a lot of clients and businesses to do ergonomic risk assessments. And part of that will be looking at going through the whole process of looking at what the different tasks involve. And then actually by looking at what the tasks involve, picking the most suitable tools to then complete the risk assessment. So it could be that if there is some manual handling element, then we would maybe use the more suitable tools to do that, like the MAC or the RAP or the VMAC, which are good tools that HSE provide. If that maybe is combined with some repetitive nature, we might then actually use the ART. And then again, it's looking at what the overall different risk factors are. So often you can combine them. But if the task is purely manual handling, then you can keep it separate. But I often get involved with doing sort of the whole thing within ergonomics.
Lovely. Oh, we've got some more questions coming through. Brilliant. Chandni says, perfect, thank you. Great presentation. And Elizabeth is asking, do you deliver, this is a great question, do you deliver or would you deliver sessions on maintaining good posture?
Absolutely. We do lots of different training and education sessions for lots of different clients, depending on what their needs are. So yes, and again, one of the key things for me is making sure that whatever what we deliver is bespoke to that, that organization as well. So it's not a generic thing, it's making sure people can then engage and relate to what you're telling them.
I think any training that we deliver around posture is always to not hold the same posture.
Yeah.
Ends up being the overall message.
Moving is the key thing. Keep moving.
Oh, thank you, Elizabeth. That's great. Thank you. There's nothing more coming through at the moment. There's still plenty of people with us, so we're absolutely here and we'll hang around as well if anyone does want to ask any questions after sort of it's ended. And again, the recording and the slide deck will be circulated to everyone that has joined today as well. few dropping off, so we'll see if anyone. Sometimes people don't want to talk or put a message in front of other people, which is absolutely fine. Oh, that's not a problem, Constance. That's absolutely fine. You'll receive the recording. So, but thank you for joining us.
Yeah, thank you.
As AHP, would our on-site, oh gosh, it moved, physio be able to complete the fit notes too? So our on-site physios, if it was a PAM on-site physios, we wouldn't complete the fit notes because we'd produce a report, an occupational health report, which supersedes any AHP fit note. So the answer is yes, they can, but we wouldn't because our occupational health reports would supersede that anyway. When showing the recording, could it come with a brief? Yes, of course. It'll be Laura that'll be sending it out, so Laura will make sure there's a brief there for you. And then we've just got Sue. Do you find most people want a quick fix and don't keep up with the regular exercise plans? How do we get through to people to get them to keep up with their exercises?
Yeah, yes is the answer to that, Sue. Yeah, it's very common. As we said right at the beginning, I think a lot of people do come along thinking it's going to be passive. They want this quick fix. We're going to sort them. And then, like you say, it's about behaviour change. And again, we go through that as part of our assessment and consultation. And it's trying to sort of, again, that advice, education, trying to give that sort of self-management and get them to understand the importance of them doing these exercises. Once they start doing the exercises and they see that improvement, then that in itself can then help that behaviour change and encourage that.
Yeah. I mean, sometimes if someone's been given prescriptive exercises for a specific condition, once that condition's resolved, if it's an acute traumatic onset issue, then generally they don't necessarily need to maintain that specific exercise prescription, but there will be long-time lifestyle changes that we would ask people to commit to. And it is exactly as Trace said, it's about the education of understanding why it's important. And any good clinician will absolutely be able to get the individual on board to understanding why this is good for their body and for their health and for the longevity of their life and future. And that's what we absolutely aim to do. There's a really good one here as well that's also from Sue. It says, often asked how much pain or discomfort a person should be experiencing, as they are often frightened they are doing too much and hindering their recovery. So do we know what is the right amount?
It varies, but one of the bits of information or guidance I often give to patients when I'm, maybe progressing them back to work, giving them any sort of exercises or activity to do, is it's learning to sort of understand their body. So I'll often sort of explain to them what a normal tissue reaction would be to some of the activity that they're doing. And actually there is an expectation they will get some discomfort and pain. That's quite normal, and they're not doing any damage. But sometimes if someone's doing something and they're getting some discomfort for a long period after, it just could be that they're exposing their body and those tissues to something that it can't quite cope with at the minute. So sometimes it's then just adapting what they're doing. So rather than stopping activity altogether, it's then giving them the ability to understand it's not going to be causing any harm, but just adjusting things accordingly.
Yeah, and I think a big thing to recognise here is that pain isn't actually measurable. It is so subjective. So yes, we've got a numerical rating scale that we ask people to sort of scale their pain on, and we've got a visual analog scale that we ask people to scale their pain against. But I can't tell someone what their pain score is. They feel their pain, they understand what they're experiencing, and they know how it affects them. There is no scientific way on the planet to take two people and say you've got exactly the same levels of pain, because it's how you score it. So it's not I can put a score on it and say, oh, if you're scoring more than a 3 on the numerical rating scale, you're doing too much, because my 3 will be different to someone else's 3. And how I feel my pain, how it affects me, will be completely different to how someone else's pain affects someone else. So we have to work with an individual's functionality associated with their pain and what it is and isn't allowing them to do. So that's a long and convoluted way of saying yes, there is a right amount and a wrong amount, but it is absolutely related specifically to any individual and their experience of their pain.
Yeah, and as I said, as we're both saying, it's getting them to understand what's right for them and how they can adapt it accordingly for their needs.
We've just got another question here, but it's nice that they're coming through. Chandni has asked again, does your online exercises link that you send as part of the assessment log how many times the person has logged on? Yes, it tells us how many times someone has logged on. However, just because you've logged on doesn't mean you've done it, because it'll also say, please score this. And if you don't log it or score it, then we don't know. And if you haven't clicked, yes, I've done this exercise and my pain score was this, then you're not evidencing it. So I can, I as a clinician may send out an exercise program to Tracy. Tracy could wake up every morning and go, oh, I need to do my exercises. Click on it and then just walk away. Not
fair though.
doesn't tell me anything. But if Tracy logs in and goes, right, yes, I did exercise 1 and 3, and then later on in the day I did 2 and 4, and my pain today is a 6, and my EQ5D5L score is 11121, then I can see the evidence of what's being logged for that individual, and I can then track the recovery on the beautiful platform that we've got. Thank you, brilliant. I'll just see if anything's popped into here. And then anything in here. Lovely. Of course, if anyone does have any additional questions or anything else they want to pop across to ask, or any other webinars or anything that they'd like to see presented by Physio Solutions, please just let us know. Obviously, I hope the slide deck has plenty of contact details in there for you, and the website does have a contact link as well. And you are absolutely more than welcome to pop any suggestions across of things that you might like to see. It's been lovely speaking to you all. Enjoy the rest of your weeks.
Lovely. Thanks all.
Thank you. Bye-bye.